Hello and welcome everyone tonight to the interpretation of prenatal screening tests brought to you by the Capital Health Network and obstetrician gynecologist Dr. Omar Adham and from the Canberra Health Services. First, we would like to acknowledge the traditional custodians of the land we are meeting on. We acknowledge and respect their continuing culture and their contribution they make to the life of this region and pay our respects to their elders, past, present and emerging. We also acknowledge and welcome other Aboriginal and Torres Strait Islander people who may be attending tonight's event. I am Dr. Leonie Harcourt, the GP advisor at the Capital Health Network, and also with me tonight is Dr. Omar Adham and Canal from the Capital Health Network. So all participants have been muted, and if you have any questions, please type them into the Q&A section of the side panel of your Zoom window. We're going to have a Q&A session at the end of the presentation, and we'll also send out copies of the slides to you at the end of the event, and a recording of the webinar will be uploaded to the Capital Health Network YouTube channel in the coming weeks. This session has been accredited by the RACGP for 1.5 hours of CPD for educational activities. If you'd like Capital Health Network to log these hours for you, please send us your RACGP number and also complete the post-event evaluation survey and return it to the CHN by the 3rd of August so that we can register that 1.5 hours for you. So tonight we're very lucky to have Dr. Omar Adham. Dr. Adham is a skilled gynecologist currently serving as a senior gynecologist at the Canberra Hospital. Dr. Adham's area of expertise is laparoscopic surgery and surgically complex endometriosis and urogynecology. He has made significant contributions to clinical research and teaching, and he also operates a private medical practice providing comprehensive obstetric and gynecological care to a diverse patient population. So thank you very much, Dr. Adham. We'll start the presentation now.
Dr. Omar, are you on mute?
Good evening, everyone, and thanks for joining us tonight. I hope this presentation will be beneficial for you all. So I have been asked to talk about non-invasive prenatal screening for fetal genetic abnormalities. Sorry, Leonie, you're moving too fast. Thank you. I've been asked to speak, present about non-invasive prenatal screening for fetal genetic abnormalities in pregnancy. As we all know, these tests are an established option for antenatal screening for the common chromosomal abnormalities, particularly trisomy 21, 18, and 13. They also screen for other less common selected chromosomal abnormalities. A recognized advantage of those is the increased detection rate of those abnormalities, and there's a substantial reduction in the need for invasive testing. The tests entail or involve testing the pregnant woman herself and occasionally the fetus for the genetic conditions. It does provide valuable information, and it doesn't pose the risk of miscarriage that comes with invasive testing. Next slide, please. Next slide, please. Thank you. Sorry, go back one slide, Leonie. Thank you. Now, counseling should involve, or potentially the expectation from those patients is to present the screening options to them and the limitations, explanation and interpretation of the results of those tests, and the implication of a positive test result, as the possibility of potentially further testing, and those can be invasive, example, chorionic villous sampling and amniocentesis, and also a discussion about the couple's wish to whether or not have a child with special needs versus the option of termination of the pregnancy. Next slide, please. Thank you. Now, at a primary care level, I find these tips or indications to refer to a specialist services, which could be a genetic services or an obstetrician when it comes to offering the first trimester screening options. This is a moderate to a high risk part of the population. And that includes couples who are known carriers of a genetic disorder. Such couples could access pre-implantation genetic testing and also potentially IVF for future pregnancies. A referral is also sought to women with an increased probability of risk or risk of a pregnancy with a chromosomal condition. So those who have a history of a prior pregnancy with a baby born with a chromosomal condition, so a prior or a child with Down syndrome, say, for example, which is one of the most common genetic disorders. If a woman had had a positive screening test or a positive diagnostic test, and you've come across the results. Also, if the parents have a form of chromosomal rearrangement, such as a balanced translocation. Next slide, please. So there are two most commonly used tests in Australia. The first is the CFTS, which is the Combined First Trimester Screening Test, and the second is the NIPT, which is the Non-Invasive Prenatal Test. Next slide, please. We'll talk initially in details about the CFTS. It uses the following measures to produce an adjusted risk. So the first one is the maternal serum biomarkers. So this is the PAP-A and the beta-HCG, a pelvic ultrasound to measure the fetal nuchal translucency. And also it factors in or incorporates into the equation the maternal age, weight, and the gestation. The presence or the absence of a nasal bone on an ultrasound occasionally is included. Next slide, please. So the test itself provides a risk estimate for the common chromosomal abnormalities or symptoms, such as Down syndrome, trisomy 21, Edwards syndrome, trisomy 18, and trisomy 13. It is again the measurement of the fetal nuchal thickness in combination with the maternal serum markers, and also occasionally incorporates the presence or the absence of the fetal nasal bone. It is performed between 11 and 13 and 6 weeks gestation. It has a detection rate between 85 to 90%. 90% is more at trisomy 21, and then 85 to 87% for trisomy 18 and 13. Addition of the fetal nasal bone measurement increases the detection rate and brings it up to about 95 and 96%. It's important to recognize that there is a false positive rate of about 4 to 5%. The cutoff for an abnormal test result is 1 in 300. A moderate risk is 300 to 1,000. Now, so if we get a result as a primary care provider of an adjusted risk of 1 in 1,000 and above, so which works its way to up in 1 in 300 and even higher, and then a referral to an obstetrician is recommended for further testing. Now, those could be an NIPT or could be an invasive test, such as CVS and amniocentesis. Next slide, please. So there are confounding factors that will affect the results of the CFTS. Maternal factors such as maternal weight, smoking, being an IVF pregnancy, and multiple pregnancy can have an impact on the performance of those screening tests, and the impact is primarily on the maternal serum biomarkers. The maternal weight is also a significant factor that influences the technical performance of the NIPT test. So the importance of reporting, that's for us to recognize that those questions on the form are there for a very good reason. And it's quite important that we identify those and include them in our referrals to ensure accurate interpretation of these screening tests. Next slide, please. Now, the nuchal thickness occasionally, well, most of the times, we will receive a separate report of the obstetric ultrasound performed, and then the maternal serum biomarkers, and then there's a combined final report that will produce the adjusted risk. But periodically you will get the ultrasound and you will look at the nuchal thickness that's reported to be significantly thick. So that has implications as it substantially increases the risk of abnormal karyotypes, also major defects. So we know that a nuchal thickness that's above 3 millimeters increases the risk of congenital cardiac disease significantly, and that certainly requires a referral to a tertiary level fetal medicine unit for a repeat ultrasound, potentially a fetal cardiac echo at some point. So nuchal thickness of 3 millimeters is a red flag when you see that on a report. And we'll talk a little about the maternal serum biomarkers, and that is the PAP-A and the free beta HCG. So the PAP-A is quite important from an obstetric perspective. The cutoff for reduced PAP-A is 0.45, which we'll come to shortly. And that's important to recognize because there is an increased risk of intrauterine fetal growth restriction, preeclampsia, and preterm delivery prior to 34 weeks. Next slide, please. Now, what are the implications of a reduction in the PAP-A levels in pregnancy? As I mentioned in the previous slide, there is an increased risk of adverse pregnancy outcomes. So you can see the growth restriction risk is 14% with a PAP-A that's below 4.5. That risk actually doubles up when the PAP-A is below 3.3. Preterm delivery, there's also an increased sort of 2.3 risk of delivery prior to 34 weeks, and with that comes also a higher risk of preeclampsia. So next slide, please. So what do we do about this? Again, we're going to sort of increase our surveillance. So, for example, the fetal growth will be monitored more frequently. So additional potential obstetric fetal growth ultrasounds will be undertaken to monitor the growth. Consideration of additional screening tests or interventions to mitigate the risk, and that could be potentially recommending low-dose aspirin to those who have, routinely we do that, the patients who have a low PAP-A that's below 0.45, we do recommend a reduced low-dose aspirin to be taken throughout pregnancy. Next slide, please. So now we'll talk about NIPT, which is the non-invasive prenatal testing, and it basically analyzes the cell-free DNA from a mother's blood sample. The test is performed from 10 weeks gestation onwards. There are factors that affect the performance of the test, most importantly is the fetal fraction. It's the maternal body habitus, so increased weight affects the performance of the test, and the gestation, so singleton versus multiple gestation. The test again offers testing for common chromosomal abnormalities, the trisomy 21, 18, 13, and it also identifies the fetal sex and the sex chromosomes and aneuploidy. The test can be offered as a primary form of screening from 10 weeks onwards, or a stepwise method. And that's when the first trimester screening has intermediate results, which is 1 in 300 risk to 1 in 1,000. Next slide, please. So the NIPT has a sensitivity of 99%, particularly for trisomy 21, and there's a slight reduction in that for the less common chromosomal abnormalities, 18 and 13, and it has a specificity of 99%. Again, as above, these apply to singleton pregnancies. They are slightly reduced in twin pregnancies. It has a false positive rate of 0.4%. Next slide, please. So what are the benefits of the NIPT? It is very accurate, so it's almost 100% sensitive and specific for the conditions it screens for. It is non-invasive, so it doesn't pose a risk of miscarriage, and it only requires a blood sample from the mother, and it allows for early detection. Next slide, please. What are the limitations of the NIPT? It's a screening test, so any positive result should be confirmed with diagnostic testing, and that could be chorionic villous sampling or amniocentesis. It is not able to detect all genetic abnormalities, and it certainly doesn't detect structural birth defects. The NIPT is typically offered to individuals with a higher risk of having a baby with a chromosomal abnormality, such as advanced maternal age, or a positive result from a CFTS. Next slide, please. So what is it? What's the NIPT? How is it performed? And again, where do these cell-free DNA cells come from? So as I said, it measures those particular cfDNA cells from the outer trophoblastic cell layer of the placenta. And these turn over and circulate in the maternal blood, and they do reflect the fetal genotype. The cfDNA consists of DNA fragments released into the bloodstream from the normal cellular turnover. And in pregnant women, most of that cfDNA is driven from the turnover of the maternal cells, actually. However, a proportion of this comes from the trophoblastic layer of the placenta, or the placenta, and it's termed fetal fraction, which is a very, very important part of the test. As the majority of the cfDNA is maternal, the ability to detect an abnormality of a specific chromosome requires sufficient fetal fraction. So for the test to be conclusive, it must have at least 10% fetal fraction sample. So the fetal fraction and its correlation with gestational age and maternal weight, these two do affect the percentage quite substantially. So the fetal fraction increases with gestational age. That's why the earlier the test is performed, the more likely we may get inconclusive results because of a low fetal fraction. It also correlates inversely with maternal weight. The higher the maternal weight is, the more likely it is that we may get inconclusive results, or it might affect the accuracy of it. There's also some research coming up about other maternal or placental factors that may alter fetal fraction. It's been observed in certain fetal chromosomal abnormalities also, and that is important. So if you have a inconclusive NIPT and the report comes in as low fetal fraction, we have to keep these causes in mind, because it's going to help us make a decision as to whether or not we repeat the NIPT or refer to an obstetrician for consideration of invasive testing. There's an increase, another factor is there's an increased risk of abnormalities in samples with low fetal fraction, so which is pretty much what I've just explained. Next slide, please. So management strategies following failed NIPT and its implications. It's commonly recommended to proceed with, offer and recommend invasive testing after a failed NIPT in the form of amniocentesis or CVS. Now, the alternative approach to this would be to consider interpreting the failed NIPT result, Y, alongside other risk indicators. So we have to factor in the clinical background. We have to look at the CFTS risk score. Is it low risk? Is it medium risk? Is it high risk? And also the detailed ultrasound findings and the nuchal thickness. If it's deemed high risk, then most certainly invasive testing may be the best option. And for low risk patients, a repeat NIPT could be considered, particularly for early gestation. So we go back and have to remember the earlier we do the NIPT, the more likely it's that we will have a reduction in the fetal fraction, therefore an inaccurate report or insufficient. So we also, it's good to recognize that approximately 2/3 of patients do get a result with a repeat test, but this is in the low risk group. The high risk group are those who would have a moderate high risk CFTS, advanced maternal age, or a prior child with some form of chromosomal abnormality. So if the NIPT fails in those, an invasive testing is certainly recommended. Next slide, please. So this is just to, again, remind ourselves about this. This is not uncommon. There is we will have a no call result, which occurs in about 5% of the cases. The NIPT or the CFDNE is unable to offer results, and we have just discussed this in the prior slide in more depth. Next slide, please. Now, this is different. So what are the causes of the NIPT false negative results? Fetal mosaicism, in cases where the fetal DNA in the maternal blood samples doesn't accurately represent the entire fetus due to mosaicism. Low fetal fraction, as we discussed earlier on, can give us a false negative. And technical limitations, so variations in laboratory techniques or errors in sample handling can also give us false negative results, and maternal chromosomal abnormalities as well. Next slide, please. What are the causes of the NIPT false positives? Vanishing twin. So in cases of a vanished twin, the presence of residual DNA from the vanished twin can lead to a false positive result for chromosomal abnormalities if they were abnormal. And maternal mosaicism, again, if the mother carries a chromosomal abnormality in her own cells, it may also lead to a false positive NIPT for the same abnormality. The third cause of those is a placental abnormality. So certain placental abnormalities, such as confined placental mosaicism, can produce false positives and technical limitations. Next slide, please. So again, we have to remember it's a screening test. Any positive result requires confirmation via an invasive test, such as amniocentesis or CVS, to ensure accuracy. Next slide, please. So there are some genetic disorders that cannot be detected via NIPT. Single gene disorders such as Fragile X or cystic fibrosis, and also non-genetic structural abnormalities such as neural tube defects or congenital cardiac anomalies. And that's why there's the advantage of the first trimester screening is when you perform the ultrasound, you'd be able to pick up on earlier on structural deformities. And it's something I also counsel patients about. Even if they opt for an NIPT, I always still recommend a first trimester screening, which still I would recommend the maternal serum biomarkers and the scan because of their advantages. Next slide, please. So we want to touch base on prenatal screening in multiple pregnancies. It does present multiple pregnancies such as twins and triplets, unique considerations. We recognize in multiple pregnancies they are associated with a higher risk of complications and chromosomal abnormalities. The screening options and are the CFTS, and I am referring to twin pregnancies. So we still have the same options, but we just need to recognize that the detection rate for the first trimester screening is slightly lower compared to singleton pregnancies. Adding measurement of the fetal nasal bone increases that and is helpful and should always be considered in twin pregnancies. The NIPT there continues to maintain high accuracy in twin pregnancies. And it's the detection rates, the accuracy is pretty much no different to singleton pregnancies. Next slide, please. And this is just to look at the accuracy, the change amongst and comparison of singleton versus twin pregnancy. The performance of all screening tests that incorporates maternal blood biomarkers is reduced compared to singleton. So this is where the issue is. We can see for the first trimester screening in twins, the sensitivity or the true positive rates is reduced to 72 to 80%. But if we do add the nasal bone measurement, then that brings it up. It can improve it to about 89%. In the NIPT tests, twins haven't been really extensively studied. However, recent meta-analysis of 5 studies reported 100% sensitivity, but slightly higher rates of no-call results, about 5%. And that's important in the pre-test counseling. Prenatal screening in triplets is a different issue. The screening for aneuploidy should be performed with ultrasound soft markers alone between 11 to 13 weeks, which an example of that would be the nuchal thickness, fetal nuchal thickness and nasal bone. There are many more soft markers that are used for that purpose. And that is because the maternal serum biomarkers and the NIPT are not, the sensitivity and the specificity is quite low. Next slide, please. I also will lightly touch on the invasive prenatal diagnostic available tests, and these those are amniocentesis and CVS. The indications for invasive testing is having a moderate to high risk abnormal results from CFTS and the NIPT. If there were abnormal findings on an obstetric ultrasound, regardless of the gestation, generally we encounter those, on the morphology scan. and on the 3rd trimester growth scans. Family history of genetic disorders and a strong personal history with a child that's previously affected with chromosomal abnormalities. There's been a move away from this most recently, and given the high accuracy of the NIPT. And also parents who are carriers of certain genetic conditions, they are offered an invasive test. Next slide, please. So we'll talk about amniocentesis. Again, it's a prenatal diagnostic procedure. It involves sampling of the amniotic fluid from the amniotic sac under an ultrasound guidance. And it's a pretty simple procedure. It has a minimal risk of infection, and it's well tolerated. The sample, the aim of that is to collect fetal cells and biochemical markers, screen for those as well. The test is usually performed between 15 and 20 weeks gestation. Next slide, please. So we look at the advantages and the disadvantages. The advantage of it is it's a diagnostic test with almost 0 false negative and false positive. The disadvantage, and that's comparing this to the CVS, which we'll come to in the next couple of slides, is that it's done a bit further down the track. So after 15 weeks, or from 15 weeks onwards, there's a 10 to a 12, well, there's a delay, sorry, in the diagnosis, as you could see, slightly advanced gestation, which creates a substantial element of anxiety to the couple. And if a termination of pregnancy is required, and then past the 15 to 16 weeks, really it becomes a surgical termination, because the response to medical termination is less effective. Or we find medical termination past this gestation is less effective. It's an invasive procedure, and there is a 1 in 200 risk of miscarriage to it. Next slide. Thank you, Leonie. What do we actually test? So what are the tests available for amniocentesis? So there are 2. There's what we call a QF-PCR and a long-term karyotype. So QF-PCR stands for quantitative fluorescence polymerized chain reaction. And basically it's a rapid test. It only tests for trisomy 21, 18, and 13, and these 6 chromosomes. Now, those results are available 48 to 72 hours, but it is not Medicare rebated. So there's an extra cost, an added cost of $175. And then the second part is the long-term karyotype, which is, it takes around 10 days, and this is completely Medicare covered, and it does test for the entire number of chromosomes. Next slide, please. So I will talk more specifically about the QF-PCR. It's a rapid diagnostic test performed on the amniotic fluid. It screens for the common abnormalities, as I mentioned. It is a rapid results within 2 to 3 days. There's an additional cost to it, and it's not covered by Medicare. Next slide, please. What are the benefits? Well, why do we do that? It's a rapid result. It allows for early decision-making and appropriate prenatal care, as mentioned earlier on. It does screen for the common chromosome abnormalities and provides preliminary information to guide us further in terms of diagnostic testing if necessary. Next slide, please. Long-term karyotype, which is the second part of the amniocentesis test, it comprehensively studies the entire chromosomal set. It also detects, therefore, it detects rare chromosomal abnormalities and structural rearrangements that are related to those. It does take longer, so about 10 days to obtain the results. The cost of this is 100% Medicare covered or rebatable. Next slide, please. So the benefits of this is it's comprehensive. it tests all chromosomes. It detects rare chromosomal abnormalities, and it's useful for cases with complex or unusual clinical presentations. Next slide, please. Chorionic villous sampling. This can be performed transabdominally or transvaginally, and it involves collecting chorionic villi using a catheter or a needle. Sorry, back one slide, please. The sample analyzes tests for chromosomal abnormalities and genetic disorders. It's done slightly earlier, from 11 weeks onwards, so between 11 and 13 weeks. And this is because early CVS has been found to cause fetal malformations or defects, structural defects, including orofacial anomalies and limb hyperplasia in a frequency of 1 in 200 and 1 in 1,000 when we perform it prior to 10 weeks. Next slide, please. The advantages of CVS is early diagnosis, and patients can choose to have, that's a correction, sorry, an error, a medical termination rather than a surgical. The disadvantages is it's technically slightly more difficult than amniocentesis. It is for sure more uncomfortable, but local anesthetic is generally used. And there's a small chance that the operator may not be able to get enough sample, and then subsequently amnio will be performed. There's a slightly higher risk of miscarriage, 1%, and 1% risk of placental mosaicism, which is the presence of 2 cell lines with different chromosome complements within the same individual, and then that will need to be confirmed with subsequent amniocentesis. Next slide, please. And I think that's it. So Leonie,
about that, I pressed something there which I didn't expect to press. So we've got a couple of questions. I'm just checking that we are at the very end. Yep, that's the very end. So the first question we have is that your statement that the first trimester screen has a detection rate of 85 to 90% must be based on certain risk being used as a threshold for diagnostic testing. Is that threshold 1 in 300?
So your statement, FTS has a detection rate of 85 to 90%, must be based on a certain risk being used as a threshold for diagnostic testing. Yes, that is 1 in 300, correct.
And the next question we have is, we usually knew about triple or quadruple tests as first trimester screening alongside nuchal translucency tests, but it looks like we are now only using Papa-A and beta-HCG, so we're not using estradiol anymore. I think there was another one as well.
Yeah, so test as first trimester screening alongside nuchal test, but it looks like now we use, yeah, so the most commonly used is again for triplet pregnancies is soft markers on
oh, sorry, I think sorry, Omar, I think this is the second question. It's just talking about the biomarkers. In the past we were using Papa-A, beta-HCG and estradiol, so it's not for triplets.
Yes.
Yeah.
Yes.
Yeah. So estradiol is not being used anymore.
Not as commonly, yes. So the mainstays are the Papa-A and the beta-HCG.
Yeah. Can I just interrupt? We've got 3 more questions, but I was just wondering, what does a low beta-HCG mean? So you touched on low Papa-A. Does low beta-HCG have any implications as well?
So that doesn't have, yeah, that's not, you know, the mainstay is the Papa-A low levels with their implications obstetrically rather than the beta-HCG.
And is there anything that as GPs, when we come across a person with a low beta HCG on their first trimester screen, we should do anything about that?
Yeah, no.
No. Okay. So our next question is, what is your experience of patients who choose to have sex chromosome anomalies detected on NIPT, then get an abnormal result, e.g. Klinefelters? Also, I think we need to be aware that some parents are using NIPT for sex selection, i.e. they have a termination if the fetal sex is not the one they're hoping for. This is legal but hard to stop, so I think it's just your opinion on that situation.
Yeah, well, that's an excellent, the second part of the question is an excellent point to bring up. I mean, I wasn't even aware of that. I'm sure as a primary care provider, you'd come across that quite often. Just going through your question, the first top of that, the parents who choose to have sex chromosome anomalies detected on NIPT, then get an abnormal result. Yeah, what's the question about that?
I'm not sure. So I was just reading what someone's written
that's
here.
Fine.
Yeah, but so maybe it's like if they get an abnormal sex chromosome result, like Klinefelters, do they?
Yeah. So everything.
What's your experience? Has people proceeded with the pregnancy or?
Yeah. So we, I mean, even though as being an obstetrician, that's quite a very complex scenario. So genetic counseling is critical, and we're very fortunate here that we do have actually a public genetic counseling team at the Canberra Hospital, which and we also have a team in private. So any abnormal results, my common practice is to have a formal review by a genetic counselor, and then subsequently the fetal medicine, the high risk fetal medicine unit at the Canberra Hospital, so they can have a thorough and in-depth discussion about the potential implications and the outcomes and the development issues before they proceed with the termination. So certainly I would not be undertaking that discussion myself without the support of a genetic counselor. Yeah.
Could I just ask what is the kind of waiting time to get in for someone who needs to see a genetic counsellor or needs a amnio or a CVS?
So
through the public system.
Yeah, of course. Look, that's triaged very, very well. So it's prioritized based on the indication. So if let's just say it's sort of a semi-advanced pregnancy with a substantially abnormal result on your NIPT, there's really no waiting. An appropriate review will be organized in a very short period of time.
Great.
And the same principle applies to the genetic counselors too. Yeah.
Oh, that's good to hear. And we've got a few more questions. I'm going to interrupt again because I'm a co-host, so I can do that. What age can you do the NIPT up to?
The NIPT can be done from 10 weeks right through till term. There's no,
Yeah. Okay, so next question. Hi, Omar. I've had an ultrasound radiology service saying the patient does not need an NIPT, or that if an NIPT is done, they don't require the combined first trimester screen. So that was interesting because you said they do still because of the PAP situation.
That's completely inappropriate. Hello, Shema. Thanks for the question.
Yeah.
That is incorrect. Again, as I explained, the advantages of the 12-week scan is the fetal morphology is undertaken and the nuchal thickness is measured. So the NIPT doesn't detect structural anomalies. And remember, if you had an NIPT, a nuchal thickness that's above 3 millimeters, then you have a substantial risk of congenital cardiac anomalies, and therefore you really should trigger a referral to the fetal medicine unit. The maternal serum biomarkers give you an estimated risk. If they're abnormal of preeclampsia, growth restriction, fetal death in utero, and preterm labor. So that's incorrect.
Okay, we've got a couple more. How many weeks should a PAPA and beta-HCG be done? Can you do it as early as 9 weeks, or does it have to be 10 weeks?
No, you can do it as early as 9 weeks. The only reason, so it's got to be done in conjunction with the 12-week ultrasound. And I just ask my patients to do it 4 or 5 days prior. It's just so then it becomes available for them to give us the final report pretty quickly. But yeah, absolutely, 9 weeks is perfectly fine.
The next one, what are local guidelines for primary care management in early pregnancy? So the 10-week do NIPT, 12-week combined first trimester screen with the PAPA. I think you might be also able to find that answer on Health Pathways, but Omar, do you want to talk about local guidelines for primary care management?
Yes, so that's a very good question, because the answer to it is that we are to recognize that the NIPT, well, both of those, so the prenatal non-invasive testing is not a routine antenatal test. It is to be offered and recommended a discussion about the advantages, the disadvantages that I highlighted in my first 2 slides is to be undertaken with the couple. And it is the couple's decision whether or not to proceed with it. So it is not a routine test that is expected.
Okay, and I think these 2 next questions join together. So they're basically about the cost of things, and I was wondering about that. So NIPT is very expensive, and the combined first trimester screen with the ultrasound also involves an out-of-pocket cost. Is there any, do you know of any avenues where there are subsidized access to these tests, or is there anywhere where they could be done, you know, for free or bulk billed?
Unfortunately not, and not that I'm aware of. I think perhaps there's one, I think that was 2 or 3 years ago, where there may have been 1 or 2 centers that bulk billed the first trimester ultrasounds, but the quality wasn't good at all equally. So, you know, we had some issues with the measurements that were coming from those. I don't think they no longer do that. So the answer is unfortunately not.
Right. Yep. That pie in the sky stuff, hey?
Yeah, well, that's true. Yeah.
Yeah. Okay. Well, that's been fabulous. So if there are no more questions, we might wrap it up. So maybe I'll just leave it for a minute, see if anybody else has any pressing questions, and then we'll wrap it up and take an early mark.
For sure.
So I'll just highlight, so Dr. Adham has very kindly offered to give 2 more webinars. So on the 31st of August, he's going to present the next step in this kind of journey. So the identification and early management of high-risk pregnancy conditions. And then later on in September, he's going to provide an endometriosis and pelvic pain update, because I think you said there are some new updates on endometriosis that you'd like to share with everyone. Is that right?
Yes, that's correct.
Yeah.
So I think for that endometriosis talk, it really, again, will be focused on a primary care provider approach, and you know, what's commonly been done and what are the new treatment modalities available to familiarize with.
Yeah, thanks. So that's the 31st of August for identification and management of high-risk pregnancy conditions, and then the 14th of September for endometriosis and pelvic pain update. We have one last question, and I think actually this will be covered on the 31st of August, and it's on another note: when do you use progesterone pessaries and do we check progesterone levels? So I think that'll be a 31st of August issue, but would you like to comment on that, Dr. Adham?
Yes, so Shyamala, the answer is stay tuned. Yeah, that'll be discussed in details with our next presentation. But progesterone pessaries are indicated in patients who are at a significant risk of preterm birth, and we do not. So there are different indications. Yeah, so that's one of them, and we don't check progesterone levels. It's also potentially could be recommended for those patients who have a strong history of recurrent miscarriage, and the progesterone levels are checked with that particular group. That is a very gray area, whether or not progesterone is recommended without good evidence of what we call a luteal phase deficiency, where your progesterone levels are reduced in the first 12 weeks, and that could be considered as a cause of recurrent miscarriage. But this we'll talk about in more details with the next webinar.
Fabulous. Okay, so thank you all again for coming tonight, and thank you very much for Dr. Adham for his excellent presentation. CHN will send out the evaluation certificates and the certificates of attendance very shortly for you to complete. And if you'd like CHN to upload your 1.5 hours of CPD, please send us your RACGP number and return the evaluation survey by the 3rd of August. And we will put our resources, presentation slides, and YouTube recordings will be emailed out to participants who, again, complete the evaluation survey. So a little tempter for those who complete their evaluation surveys. Thank you very much, everyone, and good night.
Thanks very much. Have a good night.
Thanks.